Continuing education knows that at the end, students want to graduate, and we can help them do that because we take the time to really listen to their needs and we understand all the different options that are available across the campus for them.
We don't take a cookie cutter approach. We realize each student comes with their own story. So whether it's a part-time student looking to complete a degree program or someone just looking for online courses, we're there to connect them to the resources of the university.
Good afternoon, everyone. My name is Shaunti Meyer. My pronouns are she and her, and I am a doctoral prepared certified nurse midwife and the medical director at Boulder Valley Health Center. We provide abortion care up to 16 weeks, reproductive health care, and gender affirming care. For recording purposes, today is April 11th, 2024. It's 12 p.m., and this is panel number 18031, titled Access to Reproductive Health Care in Post-Roe America. Before we get started, the University of Colorado Boulder, Colorado's flagship university, honors and recognizes the many contributions of Indigenous peoples in our state. CU Boulder acknowledges that it is located on the traditional territories and ancestral homelands of the Cheyenne, Arapaho, Ute, and many other Native American nations. Their forced removal from these territories have caused devastating and lasting impacts. While the University of Colorado Boulder can never undo or rectify the devastation wrought on Indigenous peoples, we commit to improving and enhancing engagement with Indigenous peoples and issues locally and globally. We will do this by recognizing and amplifying the voices of Indigenous CU Boulder students, staff, and faculty and their work, educating, conducting research, supporting student success, and integrating Indigenous knowledge, consulting, engaging, and working collaboratively with tribal nations to enhance our ability to provide access and culturally sensitive support, and to recruit, retain, and graduate Native American students in a climate that is inclusive and respectful. I'm so excited to see you all today. We also want to make sure you get a chance to ask questions. We will have Q&A at the end of the discussion. We're using a note card system to receive questions from the audience. At any time during the session, raise your hand to request a note card and pencil from one of our producers in the back. Please write legibly. And if you're a student, please also note this on your card. When you finish, raise your hand for the producer to take it. They'll bring it up to me. Please make your questions brief and to the point. I'm going to now introduce our panelists. You can find their full bios on the CWA website. First, we have Asia Eaton, pronoun she, her. She's a feminist, social psychologist, and professor of psychology at Florida International University. Asia's research focuses on how gender intersects with other identities such as race, sex, or class to affect people's access and experience with power. She's also the head of research for Cyber Civil Rights Initiative, which is working to end image-based sexual abuse in the United States. I'm also pleased to welcome Karen Middleton, pronoun she, her. Karen is the president of Cobalt Advocates, an advocacy, public policy, and political organization. Cobalt runs the Cobalt Abortion Fund, which provides financial assistance to people seeking abortion care. Karen was the former president of Emerge America, a national organization that trains women to run for elected office. And Karen also served herself as the Majority Caucus chair in the Colorado State Legislature. We're very excited that both of you are here with us. I would love to turn it over to Asia to start with just an introductory sentence or two.
Sure. Hi, everyone. Thank you for coming. Thank you for your gracious introduction. And for moderating, thanks to the producers. Oh, I better move up a little. Okay, so I am a psychological scientist at Florida International University in Miami, Florida. And I have had the opportunity to do research on women's reproductive health from a reproductive justice lens, which is a framework and a practice that understands that women and girls' reproductive health is intricately tied to their cultural, social, economic, political locations. It's a framework founded in the early 1990s by women of color in their advocacy work, and it describes how women's health decisions, processes, practices, and opportunities interact with other systems that they live in. So my research is focused on a variety of topics. I have looked at the links between reproductive health and intimate partner violence, reproductive health and gender roles, reproductive health and gendered racism. And the social science research is very clear that abortion access is a key component of women's comprehensive health care, and the ability to choose how, when, and if to give birth is linked to women's educational success, economic opportunities, general health and well-being. It's life-saving, it's affirming, and if we want to improve the reproductive health of women and girls, we need abortion to be legal, safe, and accessible. And this particular panel was interesting to me because the subheading was about how restricting abortion has radiating consequences for all kinds of reproductive health care and health outcomes for women and families. So I'm excited to talk about that today.
Thank you so much, Asia. I'll pass it on to Karen.
Thank you, and it's wonderful to be here today. So as someone who's been leading a reproductive rights organization, and thank you for framing the difference between reproductive health, rights, and justice, they are different, and I tend to run into folks that want to claim reproductive justice when it's not necessarily theirs to claim, and that the idea of rights and health care access are inextricably linked but distinctive, and so I hope we can continue that conversation. So I've been leading this organization for nearly 11 years, and what I have seen, and just think about that for a moment. I'd been in elected office for 6 years. I saw maybe 1 or 2 anti-abortion measures in the state legislature between 2008 and 2010. I left to run Emerge America. I came back to Colorado. Obama was president. We had a Supreme Court that nobody thought would ever overturn Roe v. Wade. Yet we knew, the writing was on the wall, that we had folks and forces that were going to overturn everything, but we were complacent for a long time. And when I think about it, I used to always introduce myself and say, if you'd ever asked me if I would be doing this work at this stage of my career, I would not have believed you. But we are in a moment where folks have lost access to health care dramatically, and 2 more states this week, and the impact of what that will mean for reproductive health care, the full spectrum of reproductive health care. Because as I travel around the state, I've been talking to people in Cortez, Alamosa, Durango, Telluride, Grand Junction, and in most of those smaller communities, people are coming up to me and saying, we don't have access to a good birthing option. We don't have access to contraception. We don't have a clinic that I can safely go to and talk about what I need to choose when and how to have a family. So I just want to layer on what Asia said, is that when you restrict access to abortion, it tumbles the entire impact. We were never very good at reproductive health care, let's be clear. We have a horrendous maternal mortality rate in the United States, and it's actually been getting worse and not better. We have been closing birth centers. We've been losing doctors who work in the full spectrum of reproductive health care long before abortion became the front page news. And so when I think about being someone in the movement who my vision is for the long term, we must change hearts and minds. We must destigmatize abortion, and we must lean into the fact that abortion is health care, and reproductive health care writ large is underserved, under-resourced, and that we're causing great harm in our society and throughout the country, which was part of why I liked the title of this as well.
Thank you. I'm so excited to be here. All right, this is my first very thoughtful question. So I'm sure many of you know on June 24th, 2022, the Supreme Court of the United States overturned Roe v. Wade in the Dobbs versus Jackson landmark case, returning the decision on abortion back to individual states. Since then, as Karen was alluding, we've had 21 states enact bans or earlier restrictions on abortion, and we've also had 21 states expand access to abortion by adding legal protections. New laws are changing constantly. Just in the month of April, we've seen Florida announce a more restrictive 6-week ban, and Arizona reinstate an 1864 law banning nearly all abortions. Knowing this legal war is not over, how do you see us moving forward in such a divisive country?
You want to take that?
I'll let you decide who gets to go first.
I'm a social scientist, so I feel like most people can get on board with the idea of evidence-based care, policy, law, and practice. And we know that having access to abortion and other forms of critical reproductive health care improves outcomes for women, children, families, men. So I would, encourage an investment in practices that are evidence-based, and to the extent that we can agree that while abortion should be rare, we know that the way to reduce abortions is through education. It's through laws that protect women from intimate partner violence. It's from having all kinds of health care available. So, if maybe we can't agree on making things evidence-based, but if we can agree that abortion should be a rare event, then the evidence is clear about how to do that.
And I'll take a slightly different tactic. I don't believe that we should, I don't think this is a divisive issue. I actually think that a majority of voters believe that government should not be involved in your health care, and there's been a partisan push to make this a political issue. So I'll tell you a little story. In Colorado in 1967, we were the first state in the nation to decriminalize abortion. It was run by a Democrat and a Republican, and it was signed by a Republican governor who went to his grave believing that it was one of his legacy pieces, was decriminalizing abortion in the state of Colorado. Most of the Republicans that we sent to Congress and the US Senate, and they were mostly Republicans in those days, were also believing that abortion should not be an issue that government interferes with. And when you think about government not interfering with abortion, that also means I shouldn't be interfering in your decision about your health care. And we've had an overly politicized narrative for many years that has tried to sort of demonize abortion. So I actually don't use the idea that abortion should be rare. Abortion should be on the menu of things you talk about with your healthcare provider, and why do people get abortions. It could be something is going wrong with the unborn baby or the fetus, something is wrong with the parent or the person who is pregnant, because if you have a heart condition, if you have high blood pressure, you have some other reason you can't carry that pregnancy, or there's another reason that is not up to you or me, we believe that people should just simply have the access, and it's a matter of fairness, and it is a human right. And it's in fact a right we had, even though we didn't really have the access we needed. And so, especially right now with the narrative on the national stage, I did a radio interview in London 2 days ago, and an AP reporter was on talking about this conflict or this challenge and this even approach to two sides, and I don't see it as an even approach. I see it as constructed by folks that want to politically divide us. And I believe, and I have talked to Republicans, Democrats, unaffiliated voters in Colorado over many years, and most of them believe government should not be a part of this. And I do think that in Dobbs, that's elevated the conversation to the national stage. Colorado's been talking about abortion for years because we've had ban attempt, 50 bills, 4 ballot measures, all voted down in a bipartisan way. And that when Dobbs passed, we now have the rest of the country talking about abortion. You did not turn on headline news prior to June 24th of 2022 and hear many people say the A word. And that's part of the problem. And reclaiming the word, I have plenty of people, not plenty, but some who will pull me aside, can we just not say abortion? It would be so much easier. It was like, we thought that for about 30 years and look what happened. So we have to own the language, destigmatize abortion, and move forward with an idea that we should all agree we shouldn't be telling each other what to do with our own bodies. And if we can move forward that way, that would be a great positive and new way of thinking about reproductive health care in a post-Dobbs world.
I just want to say thank you, Karen, for that framing. I really appreciate it. I agree that it shouldn't be a partisan issue. I agree that 60% of individuals in the U.S. support abortion in most or all cases. It's a real small minority of people who feel abortion should be banned. And I don't particularly believe that abortion should be rare. It was a sort of an effort to find a framing that people could unite around. Yeah. But really, if abortions are increasing, if that means people are getting access to the health care they need, that's a good thing.
Correct, yeah. And the other thing to think about Colorado, again, we are a national model, and lessons can be learned in other states, is we were one of the first states to implement and study long-acting reversible contraception, and we reduced unintended teen pregnancy in the state of Colorado by up to 50% in most counties. It was groundbreaking work. It was 10 years ago, and it was done by private research and funding that transitioned into an increase in family planning dollars in the state of Colorado. And we share that model across the country with both Democratic and Republican governors' offices that then implemented it at the executive level. So we know how to do a better job of reducing unintended pregnancies. But to be clear, the reason you're seeing an increase in abortion is because more people need access to abortions from states that can't get it, and they are now coming to states that do a better job of reporting it. So that's part of what you're seeing is Colorado is providing more abortions because one of the largest states in the country from a population perspective completely banned it, and we're one state you can drive to. So just a perspective.
She's referring to Texas.
Yes, yeah. Texas.
Yes, we have a lot of patients coming to my clinic from Texas. Thank you. Okay, next question. Another consequence of overturning Roe has been an increase in reported violence against abortion providers and clinics. Unfortunately, we know that that's not new. Of course, in Colorado, I'm sure many of you remember the 2015 shooting in Colorado Springs at one of our Planned Parenthood clinics. But the National Abortion Federation has data that in 2022, protective states were targeted and there has been an increase in violence. As abortion continues to be a topic of discussion and debate in the upcoming election, what advice do you have for abortion advocates, providers, and patients on the psychological impact this has?
One example I would use is Julie Burkhart, who took over Trust Women in Kansas after George Tiller was assassinated while going to church in 2009, and Julie picked up Trust Women and kept it moving for many years, and she has since opened an abortion clinic in Wyoming. It was in the New York Times a few weeks ago, and that clinic was firebombed shortly before opening, and she basically said, you're not stopping me, and she opened that clinic anyway. And so I do think one of my messages is be brave. I have not seen, yes, there is clinic violence, but one thing that I have seen is as you normalize abortion care and more people provide it, most of the clinics we work with do not experience clinic violence. Most of the clinics we work with are delivering babies and performing abortions and putting in IUDs and doing birth control appointments. And when I was meeting with doctors when I first started versus now, they were more fearful about talking about what they did and where they practiced, and I have seen that change. So in an environment where we say, we're proud of this work, we want this work to continue, we do not see the Operation Rescue style assassin list that we saw 20 years ago, which is a good thing. But I know there's still violence, but I also think we need to be bold, and we see a lot more providers coming out, speaking publicly, going on the record, testifying in committee, and we see their hospitals and insurance providers also speaking up and supporting this. Kaiser provides abortion in-house now. Denver Health is now providing abortion care. We have people moving from other states and coming to Colorado to be OBGYNs that can perform abortions as well. So I believe that we can push back and stand tall, and we have to be careful, but I don't think we have to be so cautious that we don't provide the care, and so I try to be balanced about it.
Yeah, interesting. I don't know about the rates of increased physical violence against care providers, but certainly the level of stress is probably gone up. And it's funny because we think about hazardous and dangerous jobs as being mainly occupied by men, but when you take into account psychological stress, there's women work in schools and women work as OBGYNs, and these are not stress-free situations. In fact, they're at risk for anxiety, depression, and violence, physical violence, psychological violence, and that relates to lower job satisfaction and turnover. And so, I would recommend potentially care providers unionizing and getting hazard pay for the psychological stress. And us sort of investing in trauma-informed practices in these clinics so that folks can have psychologically safe working environments.
I'm glad I'm sitting with a psychologist today. That's very helpful advice. And I would say you're right, and the group that's really important to consider are abortion funds. Abortion funds have been run like bake sales historically. That it was volunteer driven, it was a few dollars here, a few dollars there, and that model has really led to a high degree of trauma for people who are trying to help someone get access to an abortion, and they simply don't have the capacity. So we've moved to funding. We pay for all of our staff who work in the abortion fund. We don't do volunteer model there intentionally, and I think that thinking about that is really important. I do agree around trauma-informed, and I also think that understand the stress of not being able to talk to someone about the healthcare they need. So I'll just give you one story. One of our OBGYNs, who's very thoughtful and outspoken about this work, was dealing with a patient who had an ectopic pregnancy in southern Texas and who needed to come here to get a procedure that's life-threatening. So she got in her car with her husband and her 2 kids and drove here 19 hours. Now, if you've driven from Texas to Colorado, there aren't a lot of hospitals. So if that pregnancy had ruptured, it would have been catastrophic. And the impact on the doctor who knew that this was happening, knew that they were waiting, caused her to really have to take a break and step back because she was so traumatized by knowing that she was helping someone who she couldn't help that much. And I've heard from a lot of the banned states that healthcare providers who literally cannot tell you what your options are, it's like we're tying their hands or putting them in handcuffs without having anyone break the law. It's really tragic.
I know I'm not really supposed to be part of this panel. I'm just moderating, but working at an abortion clinic, I can certainly tell you that what's really important to all of us is that we understand when people are more stressed, and we just are a family and provide support all the time to each other and check in, and we enter the building and leave the building together. We never leave anybody by themselves. We have cameras. We have a very good relationship with the police department, and they can get there really pretty quickly. So I think having pieces in place that you have control over is really important in a potential situation where you don't have control. So, thank you. And you started talking about abortion funds, and that was my next question, so this works well. So we're very thankful for the Cobalt Abortion Fund. It helps people needing financial assistance to obtain an abortion. Again, with kind of this ever-changing landscape of legality, how do you remain agile in addressing the gaps and the needs of people in abortion deserts?
So this is an interesting question. So again, I feel like since I've been in this role, I've been adjusting to the movement and trying to figure out how do we respond. So when I first started in 2013, 2014, I met a woman who'd been working at an abortion clinic, for an abortion fund as a volunteer. They'd been running it. And she was the only person who answered emails for the last 8 years. Full-time job, in her 70s, and was also doing this. And we started talking about whether we could partner with the fund, because I saw the writing on the wall that the need was going to get greater before it was reduced. And we ended up partnering with them in 2017 and taking it over. And they were raising and spending about $60,000 a year. We moved that up with some staffing up to about $250,000 a year, and then Dobbs hit. So in 2021, we spent $221,000 on abortion care and practical support, which was a brand new thing, which means travel, food, some of those things. And this past year, we spent $1.25 million. And about half of that was practical support. And in the first 2 months of 2024, we now have new tracking. We're on Salesforce, and we've moved to a new model. And I now have 4 full-time employees who do this work. And they have already tracked. We spent $300,000 on practical support in January and February alone, and $250,000 of that was Texas only, people coming from Texas to here. And then Colorado is the second state, because we still need to help people in Colorado. So I say that because we made a commitment in the fall of 21 when SB 8 and Texas fell, and we lost abortion access in Texas, is when we saw a complete jump in our work. We pledged that we would not turn a single patient away, and we would spend from other areas of our budget to meet that. This year is going to be our witching year, like whether we can actually raise the money to do this. So if you know anyone in Texas, no. But we're trying to figure out how do we scale to meet this, because the demand has only gone up and it's not slowing down. So what I see is we will help everyone within our power. We also don't know where the end will be. And with these 2 new states, it's really a crisis. So what happened right after Dobbs is people in Texas who had resources started sending them to states like ours, and we can do that. But we're really concerned because this is also, think about any other area of healthcare you might encounter. The fact that you need to call someone on the phone and say, can you help me pay for my abortion? And can you help me fly from state X, pay for my babysitter, book my hotel room. Some people have never traveled before. So we are doing our best, and we've moved to a case management system because that means I know exactly how many patients we can handle with the staff we have, and if we need to add a staff to support more patients, we'll have to make a decision about whether we can do that. But I also have a whole other organization to run, and this is a piece of it. So know that I think the entire state of abortion funds are, one, too many of them are not resourced to grow the way we need them to, and we're relying on the least well-paid of this whole reproductive healthcare space, and meaning volunteer, to do a bulk of this work all across the country, which I think is a really tough situation. So from a movement perspective, I've been saying for a long time, we need to resource abortion funds to keep doing this work while we fight for changes in the law and getting people to pay for the health care that you have the right to access.
Thank you. Okay, next question. So after Roe v. Wade fell, both sides of the debate began implementing new and creative ways to advance their values. The abortion rights movement implemented telehealth for medication-assisted abortion and enacted shield laws to protect the prescribing providers. Abortion opponents have implemented vigilante laws, have targeted mifepristone, and most recently, Alabama declaring that embryos created via IVF should be considered children. What creative ideas do you anticipate being brought forth in the future on either side?
Well, I don't know if this is creative, but we can't give up on legal solutions. In Florida, for example, we just got abortion put on the ballot to be enshrined in our Constitution at the same time, more or less, that the state put out a 6-week abortion ban. But we got something like 1.5 million signatures to get this on the ballot. So we can't forget about legal options. I mean, creatively, I know that there's people sending drones across borders with abortion pills, but that's a short-term solution. You know, there's telehealth, which is fabulous. We'll need medical organizations to get on board with supporting doctors in becoming licensed across various states, licensed to practice. You know, we can invest in teaching more about reproductive health care in our public institutions. One of the interesting downstream consequences of criminalizing abortion has been that in states where there are severe abortion restrictions, people are not going into OBGYN practice as often, and in fact are choosing other specialties or going to practice in other states. Graduating medical students are you know, making choices based on their state level policies. So we need to find other ways to support these students in serving their local communities in specialties related to reproductive health care. So public funding of that kind of education.
I'm trying to think about the best way to respond to this. So one, I see in terms of creative, putting abortion rights into the Constitution, and we're in the process of doing that here in Colorado, and we wholeheartedly support Florida doing that. We have seen I'll call them the shenanigans, the anti-abortion movement through a group called Americans United for Life for many, many years was pushing for incremental bans on abortion, it was sort of tiny cuts to eliminate abortion access through other laws. So TRAP laws were targeted regulation of abortion providers. We had personhood. We had the idea of born alive, which is a notion that was basically just it was kind of the ick factor types of bans. Let's just make it sound so gross. We probably don't want to. We probably want to regulate this. And if you're and then the medication abortion information. Abortion Reversal Medication Information Act or something like that, where they would say, well, we really think that halfway through your abortion procedure, meaning you've taken mifepristone and you haven't taken misoprostol, that you're going to want a change of heart, and if you go get big shots of progestin, it'll restart your pregnancy, which is so medically bad that they actually tried to do some research on it and they had to cut it short because it caused harm to the patients. But it was basically junk science, and it was an attempt. So this was happening up to the Dobbs decision. And what they did was, not only was it, let's do all these incremental things, then they got the whole Supreme Court, so that was cool. But then the next wave was, what can we send up to the Supreme Court to overturn Roe? And so Dobbs was the one that won, but we had many presentations of all of the legal cases that were being moved through courts across the country in order to ban abortion. So this was part of a very long game. And so the bans and the things we're seeing now are sort of the tail end of a big wave of a movement. So that's the way I think about it. And I think standing firm on the fact that people This is why I go back to the majority of people. And if you, the way you ask the question in polling, you get pretty strong results. So the polling I had in going all the way back to 2014 in Colorado was, that a woman should be able to make the decision about whether to have an abortion, that should be left to, her partner, her faith, her doctor, and when you added not politicians, it was in the high 80s. And if it didn't say politician, it was, low 80s. So it was really, and it was sort of mind-blowing that I think the way you ask it about government interference around who should be deciding, I think when people get a question sort of without context, they might move. So some of those numbers are a little squishy on the national polling, and it depends on how you ask it. So I'll stop there.
This next question was written by one of the panelists. This panel is predicated on the idea that abortion access is tied to all aspects of reproductive health care. What are some examples of how the restrictions on abortion affect reproductive health care generally?
I wrote this, but I think we've talked about some of this already to some extent. We've talked about the fact that abortion restrictions mean clinics are closing, which means people can't get all sorts of forms of care, and that clinics that are still open are overcrowded and there's long lines. We know that people are changing their medical specialties in states with restrictive abortion. We know that training in and care for life-saving, procedures like miscarriage and ectopic pregnancy is at risk because of abortion restrictions. We know that there's higher maternal death in states that are abortion restricted, and higher infant mortality. It's scary.
Yeah, today is the first day of Black Maternal Health Week, and we have a significant maternal mortality crisis in the United States that predates some of these recent decisions. And what they're seeing is most other countries in the world have moved to lower those numbers, and ours are going in the wrong direction. And the death of the maternal death of Black women in particular is extraordinarily high, and there are some famous cases, right? Serena Williams, and there's someone who was sports or cheerleading in Missouri recently died, but it's specifically Black women not being listened to, and also the level of stress that they're experiencing living in facing racism on a daily basis that helps with that stress level, and then not being believed, not being listened to. So if you think about it, that's one piece, so that when you have a crisis around reproductive health care, you have other issues that have been going on already that haven't been good enough. And let's talk about sex education. In 1989, right out of college, it was my first letter to the editor. I was so excited. And in 1989, I was trying to protect access to sex ed in Massachusetts, a state that, by the way, offers it. But we have people that don't understand their bodies. They don't understand how they got pregnant in the first place. They're being faced with making decisions when they don't have the information. And we, as a society, have done a terrible job of really leaning into, let's know about our bodies, let's know about pregnancy, let's understand all of this, and let's not demonize all aspects of it. And then, if you don't have a lot of information and then you're being asked to talk about access to abortion, you may not even know what that means. And we've done a really lousy job of that as a country. And we had a president who for many years was putting in abstinence-only education, which we have barely been able to get undone in a handful of states. So I do think that that is part of the crisis that we're in. If you don't know how you made the baby, or how having a baby works, or the fact that a pregnancy is one of the most dangerous times in a woman's life in terms of her health care, there's so many things that can go wrong, and we romanticize it without the real risk of being careful and some of those things, and watching your blood pressure. So I sort of marvel at how little progress we've made, and I think as a country we need to really lean in once we get through this immediate crisis of someone needs access to health care tomorrow, where are they going to go?
Thank you. I also just, I would like to expand and say that I know historically this has been a primarily woman's issue. Boulder Valley Health Center used to be Boulder Valley Women's Health Center, and we definitely know as we get more comfortable and more open with sexuality and identity that we need to also recognize that we have people who identify as male or non-binary or gender expansive that also are experiencing this as an issue. So I know as a culture it can take time to evolve our language, and so I would just also encourage us to use patient or person when we're talking about abortion rights, because it does affect all of us. Thank you. I'm going to move on to audience questions because we have several. Thank you so much, and there probably will be enough time if there are more people that want to add additional questions. Just raise your hand for one of our producers in the back to help you with that. So the first one, and I apologize, I can read most of these, but if I miss a word, please feel free to help me out here. Are there now more opportunities for medical professionals to get training in abortion care? And if so, can that be reversed?
I meant actually,
Sorry.
not.
If not, how can that be reversed? Thank you.
You can get the training.
Yes, yes. Well, I can tell you, at least from my perspective, that I know that just in my tenure as a nurse midwife, that has expanded in addition to also providing gender affirming care. That has grown. Our scope has grown since I've been a midwife. And I don't imagine that reversing. I know that wasn't your question, but all I see is us expanding in the national organizations that put in the regulations for what a provider's scope of practice is. The majority of the medical organizations that are the national organizations that regulate what providers can do within their profession are very focused on science and evidence-based and what is going to be the most helpful for the patient. And so I have seen, just in my career, expansion of that and only see that continuing to happen. I know that specifically with gender affirming care, and I know we're not talking about that here, but that is now a part of medical training that people are getting that I didn't get when I was in my training. I learned by going to conferences and from other people. So that is becoming more an integral part of medical training or nursing training. Yeah, no, it's great. Thank you for that question.
Could I quickly expand on that?
Yes.
I just wanted to offer that, give you an example of something Cobalt does. We just did a roundtable with Senator Hickenlooper about 2 weeks ago, and we brought practicing OBGYNs, we brought residents who talked about making the decision to come to Colorado for their training as a way to know. They were literally looking at, where am I going to practice as an OBGYN, and they made the decision to come to Colorado, and expanding workforce and what those issues were. And so we had about 15 people in the room with the idea that we elevate this narrative and help people understand that. We also see more family practitioners and primary practitioners. We also have midwives and nurse practitioners trained in abortion care here in the state, and there is a law in Nevada that they're working to overturn by the ballot to expand who can provide abortion care in Nevada. So it's not just doctors, because we know that midwives and nurses can be trained to perform abortions. So.
Yeah, and thank you for that. The other thing is that the majority of people that I've interacted with who know how to do abortion care are trained in abortion care and many other things. As medical professionals, and I include myself in that, we learned, and we had a learning curve when we were first starting out, the opportunity to pass that along to future providers in a precepting arena is so valuable for our profession, and the vast, vast majority of providers that I know are very happy to take students. People can reach out to places individually or through their medical program to request clinical rotations in specific places that they're interested in working and gaining skills on. So generally, the medical community who are already trained are very, very willing and able and wanting to share that knowledge with newer providers that are coming into the system. Yeah. Okay, on a personal level, what advice do you recommend for people wanting to have open conversations regarding abortion rights but are unsure of how to approach it?
You want to take that? You want me to?
Sure, I could
Okay.
try. I think you touched on the fact that this is about bodily autonomy and politicians not interfering with our personal decisions and our medical decisions. So there's that angle. There's also looking at the many ways that abortion access improves health and well-being and economic prosperity for women, families, and their partners. So you could talk about the government interference aspect. That might appeal to some people. You could talk about the downstream consequences for society at large when people have their health care needs met.
So one study, and you mentioned economic impact of access to abortion. The Turnaway study by a research group, the acronym is ANSIRH, is a great longitudinal study. So if you wanted to take it from an academic perspective, I read this article, and here's what it said, and there are NPR interviews and other research stories that have come out of that. But that is a study that basically says what happens longitudinally if someone wanted to access an abortion and was either able to or not able to. And it was things like they were in a domestic violence situation and they were able to get out and move on and have a child with someone who wasn't hurting them, or they were able to finish school and this happened. And if they didn't get access to the care, what happened to them and what happened to their child? So you could think about it that way. What I find is personal stories are really impactful. We are in the process of gathering signatures for a ballot measure here in Colorado to protect abortion in the Constitution. And we have been overrun by volunteers, most of whom have their own abortion story or one of their friends. And last night we had a fundraiser here in Boulder, and the woman who was hosting us told us her abortion story from 1968. And so often, if you're trying to start this conversation, you could either share a story, ask someone else to share their story. Another fabulous story I would share is one of our board members read her mother's story. Her mom told her a story of being raped by their minister in Alabama in 1965 and getting access to an illegal abortion, and how she was able to do that and what happened. And that story has since been on the front page of the Denver Post. So we think storytelling is incredibly powerful, and you can share your own story, or you could say, look at that study and think about, read a story that someone else has shared and communicate that. That is a very powerful way to break down barriers.
Thank you. And I just got another question that is very related to this, but specifically if you are from a very conservative family, is it even possible to have a productive conversation with people who believe differently than you?
I think some people are not going to ever move on this issue. There's a great article in, I want to say it was Elle magazine or 17 magazine, about a young woman who was raised in a very conservative family, and it was, I forget the name of the religious cult she was part of, and she was working for an abortion rights organization telling her story. I think for some people it's not, folks aren't movable because they are true believers, but I think a majority of people don't feel that, or not that hardwired, particularly because if you talk to abortion providers, many of them will say, I just helped someone have an abortion who said that they didn't believe in abortion and they never thought they would need one until they did. So you never know.
I mean, the issue of reproductive health care intersects with basically every other issue.
So maybe the person doesn't care particularly about reproductive health care, but they care about racism or they care about economic opportunity. Well, guess what? Not having access to abortion is a function of racism in society, and women of color suffer much more for not having that access. You care about economic opportunity. It's low-income women and other people who rely on these clinics that are being closed. And that even includes men who go for STI testing and cancer screenings and other forms of health care. So, if you care about the American dream and being able to pull yourself up from your bootstraps, well, if you can't make choices about your health care and your education as a result of not having your health care choices, then that dream isn't accessible.
What can cisgender men do to support all aspects of reproductive health care? How do we get more men connected to these issues?
I think men have an important role to play in this. I think every one of us has an important role to play. We have at different times gathered men specifically, but to your point, we've moved away from gendered conversations, so we've moved away from that, but we have often historically said allies for reproductive rights and invite men to the table to maybe talk with other voices to feel supportive, but we think it's very important for every one of us to be focused on the issue, and you're always welcome in anything that we're doing.
And I think Hello. I think it also goes back to the conversation that we were just having as far as just talking about it. In the communities that you are in your friend group, in your family group, this is an important conversation to be having. And so if you have a variety of people who are with you, I think just generating discussion around this topic will include more people in this conversation. Do you know, or can you share the status of Colorado ballot initiatives to get reproductive rights in the Colorado Constitution? And same thing for Arizona. A little bit more.
So I co-chair Coloradans for Reproductive Freedom, which is the issue committee that is putting proposed Initiative 89 onto the ballot. You're welcome. We are getting ready. We will be turning in our signatures next week. We believe we will make the ballot. We've been working on this for several months. We actually started working on this in the middle of 21. Once it makes the ballot, then we're talking to voters all across the state, and we need to win with 55% of the vote come the November election. In Arizona, they have collected the signatures, and I believe if they haven't been approved, they're working on it. I will tell you the difference between Colorado and Arizona is Arizona has election laws that allow them to, I'm just going to say, monkey with ballot language and whether it gets put on the ballot the way you wanted, which is what we've seen in Ohio and other states. In the state of Colorado, that is not allowed. So basically, if voters have said we want to see it on the ballot and you meet the right number of signatures, they can't just say, oh, whoops, later. So I would anticipate we will see both of them, and I think that the latest debacle in Arizona, or opportunity for people to be faced with the truth of what they believe, it'll be an interesting time in Arizona, but I fully expect that they'll be on the ballot as well.
Asia, how are you feeling about Florida?
I am feeling hopeful, actually. I feel like this constitutional amendment is going to bring people to the voting booths. And while they're there, I hope that they vote on a number of other issues related to human health and well-being that affect reproductive health care and outcomes. So I'm feeling hopeful.
Didn't your Supreme Court say yes to that?
Yes,
so
it did.
Yes.
Yes, it's moving forward.
Yes.
When is the vote? I don't have the date.
It's not at the election time.
I'm not 100% on that, sorry.
It's November.
Is it November? Okay.
And so to follow up on this, there was also a question about the potential of a national ban, and if you have any thoughts about how that could affect the individual state movements to making them constitutional rights.
A national ban is wildly unpopular. See headlines from the last 8 days or so. We have the leader of the Republican Party, which has taken a firm anti-abortion stance, saying we're just going to let the states decide because the numbers show very clearly that it is not popular among voters to ban abortion. So I don't think a national ban would survive. And then Diana DeGette is a congresswoman who co-leads the pro-choice caucus in Congress alongside Barbara Lee from California. And they have the highest number of members they've had in her 27 years in Congress. So I believe that a national ban is not politically popular among people, and it's not policy popular among the folks that are currently elected or who would likely be elected.
This is my last question, so if anybody has any more, please write them down and bring them up because we're a little bit ahead of schedule. I think it's Tabor law preventing CU from providing abortions to students on campus. Do you see this changing? Can you explain why CU does not provide abortions?
Oh, yes, I can. The 1984 constitutional ban on abortion in Colorado is that you cannot use state dollars to provide abortion care. And so if you're a state employee, if you work for CU, if you work for a university, you're a firefighter, you're a teacher, your public insurance, even though you're paying into it most times, right, is not allowed to cover abortion on the list of things that they're allowed to cover. So the ballot measure that we are putting forward is both putting protective language in the Constitution to say you have the right to decide whether or not you want to have an abortion, and it's removing old language, which is this ban. It's an unfair ban. There's no fiscal impact on that. It doesn't cost taxpayers $1. And why is that? Well, if you think about it, your insurance pays for what your insurance pays for. It's a list of things, and we've literally just taken something off the list. So it's not going to cost the state to say you ought to be able to decide what your insurance covers. So whether you're on public insurance or some form of state employee covered insurance, that ban will go away, and CU will be able to provide abortion care on their list of services. So that's why that ban exists. It passed by less than 1% in 1984, and that's what part of what we're fighting to protect and expand this year. It's a matter of access and fairness.
And in the meantime, I know of at least 3 places in Boulder that do provide abortions right now: Boulder Valley, Boulder Abortion Clinic, and Planned Parenthood. So there's definitely access for students in the Boulder area, Boulder County. Can you talk about states' rights as a smokescreen for a federal abortion ban? Was this a deliberate tactic?
I mean, the Supreme Court removed a federal protection when they overturned Roe v. Wade, a 1973 court decision, with the Dobbs decision in 22, and it threw it back to the states. So that's what it did. If you think about it, marriage equality was also approved by a different case in 2015, 2016, that removed the ability of states to say yes or no to whatever was happening. So the Supreme Court decision that's been had now is up to the states. So the breaking news from last week is not news, it's just what is happening now. But think about any other area of healthcare and think about your ability to access it. Making this a state's right, whether or not you can access abortion, is truly it's really unconscionable in a lot of ways when you think about what pressure. Think about any other, think about you're pregnant.
and you find out you have a lethal diagnosis or you have a heart condition. And not only do you have to make a decision about what you're doing, but you also have to book a plane ticket, take days off from work, think about all the stress, and you're already having a pretty crummy time of it, right? But the fact that we have states that are able to say, and who is saying it? Is it the healthcare providers? No, it's politicians who know zero about reproductive health care or any other aspect of health care. Should they be telling you what form of medication you'd be taking for other things? I mean, it's really kind of crazy when you think about it, but you may have.
Yeah, it's certainly not evidence-based. I mean, in Florida, the 6-week abortion ban just went into place, and a third of individuals find out that they're pregnant after 6 weeks. So you don't even have the opportunity to know whether you're pregnant or not, and the timeline has passed. So they're not looking at anything related to when people find out they're pregnant, and none of those stats. And then, of course, the day you find out you're pregnant isn't the day you necessarily get access to an abortion, if that's what you choose to do. You need transportation, you need funds, you need time and space to discuss this with a partner potentially. And it's not data-driven. It's driven by political agenda that doesn't serve our citizens.
Why are pregnancy crisis centers legal? Is there a path to shut them down on the basis of fraud, of causing harm to patient health?
You want me to start? You want to start? So there was a case in 2017 out of California, a Supreme Court case that gave pregnancy, these anti-abortion counseling centers, I like to call them, free reign based on religious freedom. And it's a dangerous decision because what has happened is in the state of Colorado, there are 3 times the number of anti-abortion counseling centers than there are actual places to access an abortion. The entire campaign around these, the funding and the structure is designed to mislead. In fact, John Oliver does a great piece, it's a few years old, of sort of demystifying what these things are. And there was a slide from one of their national conferences that said, you can help, but not too much because that's not your role. And by help, sometimes these places will give diapers or car seats, and that sounds like a wonderful solution. But what they're really trained to do is delay or prevent you from having an abortion. They want to talk you out of it. They want to mislead you. They want to offer you free things. And they target students and young people. They target people for whom English is not the first language. We tracked a center up in Greeley where they named their center the same thing as an on-campus women's center that was a resource center, not anything to do with pregnancy or abortion. It had the same tree in the logo. So we came up with an alternative site, one of my student interns, and she started interviewing people who came with their stories, and it was things like an LGBTQ kid misled and shamed when he was coming for STI testing, people being told false information, being delayed, being given little plastic baby fetuses, and really kind of misled and scared. We did run a bill last year here in Colorado. A couple of my coalition partners at New Era Colorado and Calore led on that, and has been immediately challenged in the courts, so it is on hold at the moment, but it is an area we really need to work on. And they went, instead of the freedom of information and religion angle, they went on using commercial laws for being misleading in a commercial way, like if you were selling something and you were mislabeling it. So it was a great new area of law, and we hope that we will be able to move it forward, but it's distressing. And it's distressing that they don't get much pushback, but that's the story of the fake clinics, and they are harmful. And I think grassroots campaigns, I think for students it's a great opportunity. Go in and do a visit and report on it, write a letter about it, etc. It's a really good, you're a much better target able to go in and sort of do the undercover shopper than me, and you can see what you get. But they have been very harmful, and there have been sort of the bad news bears of stories coming out of there.
And we routinely have people from crisis pregnancy centers right off our property with big sandwich board signs offering free ultrasounds. So it's present. All right, next question. Miscarriage is so common, almost everyone knows someone who has lost a pregnancy. The fact that anti-abortion laws prevent people from having the procedures and medications they need is rarely addressed. Why do you think this is the case?
You want to? I can go, but I don't want to. So, if you are, and I experienced a miscarriage and I had to go get a D&C. So guess what? It's the same procedure if you're terminating a pregnancy with a heartbeat or without a heartbeat. But when I was with Kaiser, and they were in St. Joe's, which is a Catholic-run hospital, I could get my D&C there because the baby didn't survive. But if I was having an abortion, I wouldn't have been able to be there. So a lot of people don't get into the weeds on how do you perform an abortion and how do you perform the same procedure. And what we have are people who aren't trained in it, people who aren't willing to do it. And also there's a lot of shame and misconception about miscarriage. We don't talk about it. When you've had a miscarriage, they're still saying, gosh, I don't really know what happened. Throw up the hands, and I think it's another area of women's or pregnant people's reproductive health care that is just buried under the rug. So we need to do a better job of talking about it and understanding that we need people who can perform these procedures without shame, without saying, gosh, so sorry, you can try again. I mean, real judgmental kind of language around miscarriage exists as well as with abortion. And the more we can talk about it, share, and indicate we need compassionate care regardless of why we've had a pregnancy loss, we'll all be much better for it. But I think people know, and I think that there's an unwillingness to sort of talk about it out loud because people feel so much shame. If you've experienced miscarriage, it's brutal, right? I mean, and people don't understand whether it was a 9-week pregnancy or a 22-week pregnancy, you still saw them graduating from high school, right? You still have that, and it's very hard to talk about, and I think it's hard for people to move forward. And I think we don't do a good job of taking care of ourselves because of that. So that's one observation I would make.
Why do you think some people don't pay attention to facts, data, and science in relation to abortion or other issues? I love this question.
People are not scientifically literate, firstly. It's a function of poor science education in our schools. And misinformation and disinformation is rampant. People have confirmation bias. They see what they want to see. People are driven by, non-scientific considerations like religion. Although interestingly, even if you're, driven by religion, religions have different things that they say about abortion. For Jewish people, I believe a child is considered a human upon its first breath, so, people, we need to do a better job of educating folks about science in our elementary schools, as well as sex education, which you've already mentioned.
We're just about out of time. We have like a minute and a half. Very quickly, what percentage of pregnancies result in miscarriage? About 25%. Yeah, so it's really, really, really common. Years ago, read a study where 50% of women who were not pregnant declared they would not have an abortion and then became pregnant and they did. And same thing with the reverse, had the child. Is this a very difficult decision? Yes. It's a difficult decision to have a pregnancy, if you want it, if you don't want it. It's a life-changing event, one way or the other.
And it's about 46% of pregnancies are unplanned in general. That was at least so think about it. Doesn't mean they're all having abortions. It just means most of us aren't planned. It's not like it's the most planful activity you can have. Go ahead.
And then very quickly, can you clarify the role or relationship between Cobalt and Planned Parenthood on abortion assistance?
Planned Parenthood provides abortions, and they also have financial assistance and practical support assistance. Cobalt provides financial support for abortions and helps navigate, but we don't provide abortion care. So, but we are close partners, we work together, but we support their patients, and that's probably the quickest answer.
We are at the end of our time. Thank you all so much for coming. Thank you to our panelists, Asia and Karen. Have a wonderful afternoon and rest of sessions if you can attend more.